Wonderful. So good afternoon, everyone. Appreciate you taking time out of your busy schedule to join us here tonight for the Maryland Primary Care Program Advisory Council meeting. We're excited to get started and look forward to some interesting dialogue. Before you is the agenda. We typically follow an approach that you're familiar with as we start down the pathway to discussion. So with that, let me invite Anani to make some operational announcements.
Thank you very much, David. Good evening, everyone, and thank you for joining the meeting this evening. We would like to remind everyone that the meeting is being recorded. Please contact the MHCC team with any technical issues. We sent an email yesterday with the team's contact information. As a courtesy to others, please remain on mute when you're not speaking to reduce background noise. Staff may mute you if there's a lot of background noise coming from your line. You can also mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. The meeting facilitator will sequence speakers and may also call on people to speak to ensure that we have a wide range of perspectives. Please raise your hand by clicking the raise hand button under reactions at the bottom of your screen to ask a question. Another option is to enter your questions into the chat box. So before we begin the meeting, I would like to recognize the council members who are attending the meeting today. And I'm just going to go through the list of participants I see. So we have Mr. Alan Field, Mr. Chad Pearman, Ms. Debbie Kuchka-Craig, Mr. Gene Ransom, Dr. James Trumbull, Ms. Laura Russell, Dr. Michael Barr, Dr. Michael Reedman, Dr. Peter Lopresti, Dr. Robert Berenson, Ms. Trisha Roddy, and we have a phone number 24039 number ending in 990, which I believe is Mr. Kevin Hayes. Additionally, we have from the MHCC, our Executive Director, Mr. Ben Steffen. If there's anyone I've missed who would like to introduce themselves at this time, please do so. And I see Dr. Scott Berkowitz is just joining us as well. So hearing none, I will now turn over the meeting to Dr. David Sharp to make some opening remarks.
Again, good afternoon, everyone. So before we get started, I'd like to open it up to Dr. Reedman to make a few remarks, and then our Executive Director, Mr. Steffen. Dr. Reedman, okay.
Got it. Okay, got it. Yeah, thanks and welcome to everybody. In the interest of time, as usual, I'm going to make some of my remarks brief. Thanks for everyone for their time. I did want to, before we start, just take a moment and really thank, as I think most people know, Howard Haft is officially retired. I think I saw him on the day he retired in Chad's office. But I don't think we could continue the meeting without recognizing the work that Howard's done over the decades for the state and for this committee, for the program, and his input and personality will be missed. So I just wanted to just take a second and thank Howard for all he's done for us over the years and for the state over the years. Other than that, I'm going to continue. I have a couple comments before Chad does his presentation, but I'll turn it over to Ben if he has any comments.
So consistent with the banter beforehand, I think that 2023 is really the year in which primary care appears to be elevating. And I can see that by every day this week. I think I can go to some primary care forum or another. That doesn't mean, however, that we have results yet. And I think the work that we're doing here, as well as in the primary care work group, which aims to set a benchmark for primary care spending in the state, are really important and complementary activities in the state of Maryland. Certainly, this program is one that many people, both inside and outside the state, point to as a a program that warrants further expansion and imitation across the country. So everyone should understand, we have some great opportunities. There's greater awareness of the importance of primary care. We see that as well with our federal partners, and look forward to the meeting today. Thank you, everyone, for attending.
Okay, thank you, Ben. Appreciate the input. So with that, let's travel along with our agenda. And at this stage, I believe we are going to invite Chad to get us started.
Just David, just before Chad starts, I'd like to use Chad's presentation as remind everybody that for feedback, and Chad's going to have some specific questions and information in there. So again, feel free. I'm getting feedback from somewhere. Hope everybody can hear me. I'd like when Chad goes through his list, to certainly, if you have comments, and we'll try to pause for those comments and feedback, it would be a good time to kind of do it, I think, during Chad's presentation. So I'll turn it over to Chad's capable hands.
Thanks, Dr. Reedman. And I echo your sentiments on Dr. Haft. And thanks to everyone for joining us tonight. We have, I think, it's an important time for the program, as Ben said, and lots of opportunity. And so we're looking forward to your feedback as we think about the future of MDPCP. So let's go to the next slide. So I'm going to provide just a couple quick updates policy-wise to circle back on some things we talked about in January. Then I'm going to talk through discussions we've had recently and the timeline in terms of providing feedback on MDPCP. And then we want to get into the discussion about some of those priority elements that we started talking through back in January. And I think we've refined a little bit since then. And then we'll talk next steps. Next slide. Okay, so a couple policy updates. As you know, we submitted the MDPCP annual report to CMMI back in December. We have talked with CMMI, and in past years, they have sometimes written us kind of a formal memo saying, here's what we'd like to do with number 1 and number 2, and here's what we're not going to do. This year, they said that was not part of their plans, but instead they've incorporated their response into some of the policy discussions we're having with them now. So I wanted to bring back that to the group so you could kind of hear where things are. They are considering 3 areas that we had recommended among 7 in the annual report. And those are expanding the eligible specialty codes for MDPCP. And when I mean specialties, I don't mean expanding it to pulmonologists. What I mean is how they accept specialists, how they accept the specialty code that's listed in the NPPES for primary care practices. What we've had happen over the years, as many of you know who are in the program or have participants in the program, is that sometimes what happens is the provider, maybe when they first came out of training, identified their primary specialty, let's say as emergency, and their secondary specialty is internal medicine. They would get rejected from the program when they apply. And as we're still we have 1 more application period coming up this spring, and we'd like to bring in more practices in our last opportunity here, certainly more practices in underserved regions around the state. We want to make sure that practices with providers who may have multiple specialties listed are not rejected out of hand. So they are working on incorporating that into the request for application that will come out in May or June. Then the other two items that they're considering that we had recommended, which would not necessarily be a change to the request for application, but would be a change to the participation agreements and the financial methodologies that come out in the fall. And this would be potentially for as early as 24, would be reducing the weight of the total per capita cost measure. Right now, that measure is 25% of the cost and utilization measures. And we've encouraged them that seems to overly weight total cost of care for primary care and reduce that. So they are thinking through that, and I think there'll be more discussions in the coming months about that potential. And then the other piece is expanding flexibility around the health equity or the HEART funds. I know it's a exciting area for us to address health equity, but it's also a challenging area for primary care to figure out how to use those funds. And as usual with CMS programs, there are a fair amount of stipulations around that. And we've been getting a lot of feedback from all of you and from participants in the program about ways to expand that flexibility on using those funds. So we are working on that with CMMI now as well. So I think it's promising. They're considering changing several areas, which I think are important areas. One of the other recommendations we made, maybe the top one, was making track 3 an optional track, given some of the challenges with implementation of that track and the financial model and the downside financial risk. They are considering that, but they have also said to us, given the changes that would be involved in doing something like that, they don't think it's possible to do for performance year 24, and that we will have to engage in more discussions with them and consider it potentially for performance year 25. Let me stop there, see if there's any comments or questions at this point.
I'm sorry, I can't raise my hand. I'm in a car. I'm coming back from that briefing. This is Gene. I just had a question about the comment. We're not going to have an open enrollment next year. You said this was the last open enrollment.
Unless something changes, Gene, that is currently correct.
Can we add that?
Hey, Gene. Gene, you're breaking up. So, can we let you travel a couple more
We
miles?
ask for why would we not continue to add new people to the program?
That was part of when we went through the discussions with track 3 and the transition timelines. CMMI said that they wanted this to be the last year for any new practice to come into the program, or 24 to be the last year for any new practice to come in. We have, we flagged this for them that, given that we're talking about a longer term for MDPCP, maybe we could revisit that. But we haven't made any more progress on that question. Is that something, I know, Gene, I hear you saying we should consider bringing in new practices in the future beyond 24. Is there other feedback on that? People feel strongly one way or the other about that?
This is Laura Russell. We recommend that as well, and as part of the HSCRC progression planning. We've made similar comments in our comment letter, and I'm happy to share that with you.
And I think Debbie Kuchka-Craig.
Yeah, I was just going to say, not knowing, about erosion of existing practices when they get into track 3 risk, I think that is, it could be problematic. I mean, if we don't have new practices coming in, we need a certain participation rate, I would think, in order to be successful as a program. So that would concern me.
This is Jim Trumbull. I would second that as well. And to Gene's point, and I'm not trying to steal your thunder here, Chad, but I think there's a slide as I was reviewing these earlier. We're only at about 45% of the practices in Maryland. So it sounds like we've got a lot of room still to expand. And it certainly would be an opportunity to really bring in more practices. And as Debbie mentioned, there probably is going to be some attrition of practices out of it, that especially small ones. This is what the feedback I've heard in our area, the small practices are very leery about going the full risk.
As they should be.
Dr. Bernstein.
I have a question. I can't find my question is not to help me find my raise hand function, but I'm just curious whether in getting the right people eligible, you've run into problems in the past with the people who put down internal medicine as their primary specialty, but actually are hospitalists. Does that create any problems in getting the right eligibility?
We haven't really had, surprisingly, we have not had much of that issue. More the issue is that if somebody is just, if it's just listed as internal medicine, you may know this, Dr. Berenson, it's no problem and it fits the codes. But if they're listed as internal medicine cardiology with a subspecialty, then they exclude them. And so that's where that's one of the issues, but there's an option of, you have your primary specialty and then you have your secondary specialty. Today, if you list internal medicine cardiology as your primary, you would be excluded from the program. if you list, what we're suggesting to them is make it so that what if it's internal medicine, regular plain old internal medicine in the primary or the secondary slot, allow the provider to be counted towards the attribution of the practice.
Okay, so you haven't run into institutionally based people who aren't practicing who aren't doing primary care being listed as internal medicine. That's interesting. Okay,
Correct.
okay, thank you.
So Chad, for these situations, has it been correctable upon notification? When the application is submitted and then it can be, it's revised or corrected, and then the continuation or of consideration moves forward, or it means that at the very end of the application cycle, folks are left out completely?
I can speak to that. I wonder, Alice, I don't hate to put you on the spot, but if you're on the line, you might be able to chime in because you're the expert on this area and how we've dealt with it. While Alice is trying to jump on if she's available. We provide guidance to the practices when they're doing the applications, and as do I know many of the CTOs and other organizations, on making sure that this is updated. But what we find is that practices, for whatever reason, they don't update it in time before the application goes in. And Alice would have to comment on, I don't recall whether they can fix it after the application has gone in.
Yeah, I can jump in here. So unfortunately, they are rejected very late in the year, November, December, and they need to wait until the next application cycle to apply. So it is possible for them to try again the following year, but it's not something they can fix during the same application period.
Is there a sense of magnitude here, or is it just, it's unfortunate, certainly, but it's worse if if the number is really high?
Just based off of last year, and the numbers were much bigger in previous years, but last year we had about 30 practices that were rejected and 4 of them were rejected on specialty.
Okay. Dr. Okiki.
Yeah, afternoon. My question is about expanding flexibility for heart funds. Would they also consider increasing the rate set based on the ADI? Just saying that sometimes some of the practices, the funds they have for the focused on the heart efforts or task or resources they want to invest is not significant. So just curious if this is a focus to keep addressing social barriers, if they're going to not only consider flexibility, but increasing the rates of reimbursement for that.
Has not come up, but we could certainly raise it. But to be clear, Dr. Kiki, are you suggesting raising the $110 to a higher level, or to differentiate the levels based on the level of ADI of the Benny?
To raise it up. And the reason I'm saying that is, of course, there's always that discrepancy between what CMS calculates versus what is real, to at least from the practices. So just at least increasing that, rate would be helpful to just have some more meaningful use of that fund. Because if we're going to go ahead now and start tracking what we're doing with it, I mean, how do you track $400 and $500 and things like that? So just a thought.
Yeah, no, that's helpful. And I think we can flag it for them and see if there's any appetite for that. I think one thing they would say, though, is that if you recall how they developed the heart fund, they siphon the dollars off from the care management fees. So they would probably say, we're going to keep it budget neutral. We can put more into heart, but we're going to pull it out of your care management fees. And I don't know if that's something people are going to, for some practices that may be very attractive. For other practices who will lose more on that, they may not be so interested. But it's an interesting idea. Thank you.
Dr. Lopresti.
Chad, with that reminder comment about the care management fees makes my comment slightly moot. I was wondering if there was the flexibility might be defined as lowering the ADI threshold first, and secondly, more to the point, can you define flexibility? Difference in what we can get paid for, or how do you? What would you say?
Yeah, and the missing word is use. The use of the funds. You'll recall there's a lot of gray areas in how the funds can be used, and there's also restrictions in terms of they can only be used largely for the beneficiary that's defined as a heart beneficiary. And we've heard from a lot of CTOs and practices that they're not sure whether the heart beneficiary is not always the patient in most in need among the Medicare beneficiaries, and they'd like to have more flexibility in using the funds for other Medicare beneficiaries, and or being able to use it for blood pressure cuffs, et cetera.
I did hear from another CTO in the state, or a question was posed to me, whether the heart funds could or will be able to be used for non-heart beneficiaries. So that's circulating around as questions.
Yeah,
Thanks.
and that's one of the areas of flexibility we've asked CMMI to consider.
Understand. Thanks.
Thank you.
And Chad, could you just remind everybody about the availability of the funds if they're not used within the program year?
Yeah, David, good question. So the heart funds are not at risk. So practices one way or another will keep them unless, there's some kind of audit and they misuse the funds, but they're not at risk. But practices are expected to use them during the year. And as everyone knows who is trying to finish up financial reporting right now, you have to report on how you use those heart funds across the board, just like you do for the rest of the MDPCP payments.
Okay, Chad, not seeing additional questions.
Great. Good. Thank you for the feedback. So the next point here is really to try to set up the discussion about future priorities. And I know some of you are aware there's discussions about a future model for the state, which would include a future primary care model. And I just wanted to share with you the kind of the high points that CMMI has shared with us. As many of you know, we don't have a lot of specifics, but the big points that they've shared with us as it relates to what they would like to see in primary care in Maryland and other states going forward includes the following. And the reason I raise these is because we should keep these in mind as we think about what are the priority elements that we end up proposing or including in a progression plan for Maryland and MDPCP. So those include the following, that there will be primary care investment targets, both on an all payer and a Medicare fee for service basis. Our understanding is that CMMI is very focused and CMS is very focused on increasing primary care investment as a percentage of total cost of care, both on the Medicare side as well as the all payer side. And our understanding at this point is they would probably take the lead on setting the Medicare rate, and they would expect the state to set an all payer rate. The second area is they would like to see, and you'll notice many of these things we already have, which is great, a Medicare fee for service for the Medicare fee for service population, a non-claims based payment. I think they're thinking about this as a single payment that would look something like what we have in terms of a care management fee or a population-based payment today. They're also very clear about Medicaid alignment is absolutely essential. There needs to be a robust Medicaid primary care program that MDPCP is clearly aligned with and clearly working closely with as a way to have a transformation across the Medicare and Medicaid population. And then the fourth area is a focus on health equity and social needs. Or I should say, they identified three major areas, which again, I think are baked into MDPCP, but what they're really focused on are these three: health equity, social needs, behavioral health integration, and care management. Any questions at this point?
Chad, I have a question. So MHA has been involved in these discussions generally about the multi-state demonstration model that you speak to. And we've heard that overall Maryland may be used as a model because of their GBR, and there might be some flexibilities just given we're farther along than other states that wouldn't want to participate in this model. I'm wondering if the same is true on the primary care side. I'm just thinking of some of the elements that we have, like the innovative heart payment.
That's our read on it from what we're hearing from them, that much of what they're thinking going forward is based on the Maryland model, both on the hospital and the primary care side.
Okay, thank you.
Thanks.
Jean and then Dr. Trumbull.
All right, we're gonna try again. Hopefully you guys can hear me. I just wanted to say that
Gene, we're not able to hear you. We'll come back.
strongly supported the point about the medical comments to the HSC, that and a couple other comments related to MDPCP.
Okay, thank you. We can come back to you as Gene in a few minutes equally. Dr. Trumbull.
Thanks. The only other thing I'd add is that if we're thinking along the lines that, and this is obviously looking to expand to all payer at some point, and is clearly what Medicare is looking from Maryland as far as information they're getting from us. I think this kind of goes back to what Laura was just talking about. We really, if we're going to approach it like that, and especially we talk about a focus on health equity and social needs, this is not just Medicare patients, it's not even a subset of Medicare patients, that we need to be cognizant of that when we're talking about the funding that we're providing to the practices and how we expect them to use it. And then what I'm getting at, this kind of relates back to the heart funds issue yet again, and I think my point is that as you guys go into discussions with CMS, I think this is the information that we need to point out to them, that we're not segregating out patients when we see them, that this is a Medicare patient, I can do this, even though that is the reality of what this program is approaching right now, that we really need to be more broad in how we're applying this the funding for this and how we're approaching patients in general. So thanks.
Thank you. And we have Will Daniels here on the call today. Will, I was wondering if you might have any thoughts to the dialogue that's occurring.
You mean in terms of additional flexibility or what specifically?
The flexibilities.
So I think CMS flexibility is always in the details. And so I think, we've definitely emphasized to CMS the advantages of flexibility for them. They've responded to us that they're interested more in flexibility and providing that to the state. I think it remains to be seen how much flexibility we actually get. We've not heard from them specific flexibilities that will be provided. So, I think CMS understands that in state-based models, flexibility is necessary. But we still haven't actually seen what they're going to be putting in the model yet. So TBD.
So Will, I don't know if this follow-up question is for you or someone else to respond, but part of the success factors for the MDPCP program is to have other payers participate in some sort of value-based care payment structure. So, given what James had just said, the practices are supposed to be shielded from, is this cohort of patients versus that cohort of patients. Are there any traction or talks about, I don't see that here as a bullet point, but he talks about advancing that further, that more payers also sort of align with this to sort of help the practices really truly embrace transformation in its totality if we're all going to be part of being held accountable for the total cost of care for the state.
Well, I think I can partially answer that, Dr. Okeke, and Tricia, if you want to, or anybody else wants to jump in. But I think, based on their focus on all payer primary care investment targets, as well as total cost of care, I think they're saying Medicaid is really critical, but I think they're saying we want more than Medicaid. We do want commercial in as well. And sometimes they call it multi-payer because I think they're trying to be reasonable and that not every payer will always join, but I think their ultimate goal is all payer.
Yeah, and Chad, we have Laura Goodman who might be able to weigh in. I don't believe Tricia's still with us. And she may be, oh, there she comes.
Hi, good afternoon, everyone. Yeah, absolutely. And without being too close to the details of this, Medicaid is working closely with Chad and the team and CMMI, and we're looped into the conversations on the multi-payer model as well.
Okay, thank you, Laura. And Jean, were you wanting to make another comment or, I see your hand is raised.
So let me ask a follow-up question. If Jean is not still on air, what is the timeline that we expect to see this alignment, so to speak, so that way, if we're going to, put a restriction on more primary care practices joining 2024, and then the program is still, set to end sooner, then what is the timeline for the alignment to really benefit from that synergy, right, of the alignment of payers?
I can speak from the Medicaid perspective if Tricia isn't here, and that, we have been working on a concept note. I think we are working on now aligning how that will look vis-a-vis the multi-state model, because to your point, it makes more sense to align with where CMMI is headed. And we've all been really receptive to that. And I think that one thing, to kind of start communicating and socializing with you all now is that, this is the alignment is through our health choice managed care organizations. And so it's going to be based on the MCOs that practices are networked with, offering you all, and other MDPCP primary care practices, the chance to join the aligned program, if that makes sense.
Yeah, that's very helpful. And I would also note we have Dr. Bazinski who's joined us, and I believe he may have thoughts related to this. Dr. Bazinski, are you able to speak? Okay, maybe in listen on. Oh, there it comes. I think. Nope. All right, well, we'll circle back.
So David, I'd like to just throw in a comment about the certainly how, in the practical standpoint, we were having this conversation in our annual report to our partners last night that I gave, that the reality is that the funds we're using to build our population health team, with our case managers and care managers and all, I think Howard Half was one who told me years ago that the program really was built to be agnostic, and we benefit all of our patients, our Blue Cross Blue Shield patients, Aetna patients, United patients. All of our patients are really benefiting from this because we don't really distinguish, even though it's the MDPCP is helping to support the additional personnel for this. We use this for all of our patients, and we really kind of benefit. They all benefit from it. So there is a lot of that already going on, I think, just because of the fact that we have the staff and it's been beneficial for our Medicare patients. So I think hopefully that's happening statewide to all the practices.
Very good point. Any other comments before we move on here? Debbie.
Yeah, as Chad knows, and I think maybe our co-chairs know from some of my feedback on the report and some of the other things that's been vetted with the council, I just feel compelled to share with my colleagues that I'm probably the outlier in the group regarding how far we want to take payer alignment. I am quite concerned, and again, I'm probably the only one, about going with a one-size-fits-all kind of thinking, when I don't think that any one program has really solved for all the challenges that our industry has. And so I like to think of it as a time of great exploration and creativity, so that if one payer is willing to do things a little bit differently in order to test models and get proof of concept and learn from that, then we can kind of compile all the best practices. I understand the need from the practice perspective to have, some kind of commonalities. And so I get the general movement in terms of all payer, but I get very concerned about going too far too fast in that kind of mindset, and then not being able to take the learnings that we have with certain MCOs that we're working with, things that are making sense because it doesn't fit into the MDPCP metrics or the MDPC model perfectly, or similarly with the commercials. So again, those that know me know kind of like I'm always just throwing it out there. I was feeling a little guilty just being a silent participant here with all the praise for the, all payer model, because I'm not sure I'm there yet, but I just wanted to share that with you all.
Wow, thank you very much for the feedback. Chad, back to you.
Okay, great. Why don't I keep us moving? Thank you all for really great feedback. More to come. So let's go to the next slide. All right, so I just quick background on discussions we've had. So we met back in January. We started talking about guiding principles and elements that were part of that. We took some of that to, and some of you on the council were part of these meetings. We took it to a group of leading participants in the program, both providers and other CTO administrators and other leaders in the program. And so we got feedback from them. We reviewed the major elements based on the initial discussions we had with all of you. And then we also got additional written feedback, which we've incorporated into a few slides later, which you may have already looked at, that we think boil down to the major elements we heard that are most important and or need modification going forward in MDPCP. So with that, let's keep going. I do want to say in terms of timeline, and we've also met with the HSCRC physician stakeholder group, which I know a few of you are also involved in as well. That is the group that's going to be kind of the vehicle for us putting our recommendations for MDPCP to get incorporated into a progression plan going forward. So that group is going to be meeting again on Thursday. And I believe Jean and a few others are on that group. We will share with them kind of the findings of this group, at least based on this meeting. And then I think next month, we'll share with them a more formal list based on what we're discussing today to incorporate into the plan. That's going to go through a few iterations. And then we anticipate by later this spring, they're going to have at least a formal set of physician program recommendations, including MDPCP and modifications potentially to MDPCP that would get baked into a larger plan for the state. So I think there's going to be more opportunity to see that, but this is our initial salvo, I think, at making sure that MDPCP needs are incorporated into that plan. Next slide.
And I would just say that I feel like that group is very much aligned with the direction that we're heading in. Would you agree with that, Chad?
I do, yes.
Thanks.
Thanks, Gene. All right, so let's get going. So let's talk about next slide, please. So just a reminder, there's 3 slides here with guiding principles. I'm not going to go through these bullet by bullet, but I just wanted everyone to see these. This is, we worked with David and Ben and the team here on boiling down what we heard as kind of the guiding principles. Now we pulled some of the elements out of there as well, but guiding principles for MDPCP going forward, and we put them into 3 buckets. This is the first one, so advanced whole person care. The second.
And Chad, can we pause on each one just for a moment to see if there are any comments as it relates to the categories? Give folks a chance to read and then to ask any questions if they have them.
Okay. Why don't we go to the second one? We'll do the same thing. Go to the next slide. So this is establish strong linkages with the healthcare community. And then why don't we go to the last guiding principle slide? The other big bucket is build a highly reliable program that supports and advances primary care. So as you think about what we've just had here in the guiding principles, I wanted you to see that, you know, we did take what we heard from this group and develop them into principles. But underneath that, I think is what we're trying to get into, which is the actual critical elements of MDPCP. So if there's no comments on the principles at the moment, we can always come back, but there's no comment on this. Let's go to the next slide. And let's get into the discussion about In the next two slides are the sort of priority elements of MDPCP. We have a third slide that has what I would call the other elements that are of consideration, but I think we have a fair amount up front in the first two that we want to get feedback on from the group, make sure that it represents the MDPCP community, including all of you. And if there are changes, we'd like to hear that. If people agree with them, we'd like to hear that as well. But as you're thinking about these elements, do these elements, think about these questions. Do they make sense for the evolution of MDPCP? Do they support a strong advanced primary care program for in the state? And back to the guiding principles, do they align with what we had in the guiding principles? So with that, let's go to the next slide. And I think we have 8 top priority categories. And you'll see a few bullets for each of these. So why don't I just walk through these and then we can start talking about it. And remember, we have a second slide here, but why don't we'll start with the first slide. So first, what we heard is that spending level investment in the program is critical for MDPCP. It should have an enhanced primary care investment sufficient to address medical, behavioral, and social needs. And we did hear from lots of folks that the health equity dollars need to be included there, and it needs to be substantial or additional to the program.
And Chad, can I just pause here to note that following Chad's presentation, Ben will be covering the progress of the primary care work group, which was tasked with looking at spending levels and investment.
Perfect. Thank you, David. Second area is payments. And when you see in red where it says modification, that's where we're identifying that this is different than what we have necessarily today in MDPCP. It may be a small change, but we wanted to call it out. So in MDPCP, we do have a hybrid model of fee-for-service and non-claims-based payments. But what we've heard from the group is that they would like to continue to have that hybrid model, but instead of having multiple components or payment streams for a population-based payment or care management fee, et cetera, that should be wrapped up into a single unified payment that potentially, to Dr. Trumbull's point, might have more flexibility if it's one large, if you will, enhanced payment that supports comprehensive team-based primary care that has some flexibility around using those payments. Today, if you think about like track 2, we have fee-for-service payments, but then we have a population-based incentive payment, we have a care management fee, and we also have a heart payment. The other piece about payments that we've heard is that it should clearly provide the practices with the financial resources to address social needs, either through a payment like HEART or as part of the unified MDPCP payment. In terms of financial risk, the third section here, we heard pretty universally that the requirement of downside risk is a problem. And what we heard was a slight sort of bifurcation of that in particular, having downside risk on core primary care payments, the fee-for-service payments and any other core payments that are part of our program is an issue, and that it shouldn't be required unless practices want to opt for downside risk. We did hear, on the other hand, that having downside financial risk with some kind of performance incentive payment, a la the performance-based incentive payment in tracks 1 and 2, is appropriate for primary care. And then the fourth section is payer alignment. So I think we heard pretty universally that, while acknowledging Debbie's point, universally that for providers and for practices, they need alignment on payments, on quality measures, and data to reduce the administrative burden of delivering all payer agnostic care. And so that would be a modification to the existing program. So I'll stop there. Would like to get feedback, comments on this slide. If you don't say anything, we're going to assume these are perfect and exactly right.
I will say something. So a couple of comments on that. One is just going to the payer alignment. I don't disagree with Debbie at all, but I think the issue is having multiple quality measures and multiple data that we have to generate for different payers. You know, our group has 5 major payers, and at one point they all had different programs, and worse than that, they all had different measures we had to report. And so aligning those quality measures, that's the issue that becomes overwhelming from an administrative burden. Whether the program's exactly the same payment model or not has been different, but trying to align some of the quality measures and what we're at risk for and what we're responsible for, I think would be important. One of my biggest issues is the financial downside risk, and I think that's true of all of us. I think we've already talked about the fact that there are sites and groups that aren't joining because they're worried about this downside risk. And I think the original premise of this was to more appropriately pay primary care physicians for the work they do. But to put us at risk for our basic income and our basic operating expenses, I think is a mistake. I think that putting us at risk for a true bonus that's on top of their cost savings and there's truly savings, putting us at risk for that part is not necessarily inappropriate. But asking any physician, in particular primary care physicians, to manage cost and to manage things that we are unable to manage, and a lot of the costs we don't have control over, but more importantly, to put us at risk for losing some of our basic income, which could truly bankrupt a small practice. If you lose 10% of your income, and you've already hired all these people to help you with case manager stuff, it could be a significant hit to a practice where we're already short on primary care practices and physicians. And I think that's what's holding back a lot of physicians from participating. So again, I think really importantly, not putting our core payments at risk is important. Putting a bonus payment truly at risk is not necessarily inappropriate.
Good point. Thank you, Dr. Reedman. Dr. Bernstein. Dr. Berenson, excuse me.
So I'm going to go even further than Dr. Reedman. I agree there shouldn't be downside risk. I don't even think there should be voluntary downside risk. I'm assuming that to take downside risk, you also get more upside potential. And the whole pitch that's being made by venture capitalists and others is take risk and you can game the risk adjuster wonderfully and make bundles of money. That's explicit the pitch that's being made. The risk adjuster doesn't work for practices that CMS uses. If we actually did get a good risk adjuster, that's a whole different story, but they're using the HCC model that was designed for Medicare Advantage plans. It's not appropriate for a primary care practice. So I don't think it should even be a voluntary opportunity to take downside risk, I guess is my point.
Chad, any response to that? Anything that you've heard from CMMI as it relates to the concerns Dr. Berenson has noted?
No, it has not come up with them. They are, as you know, very focused on HCCs across all their programs.
That's a huge mistake by them. I'm sorry.
Oh, Dr. Berenson, I mean, we certainly would be open to your recommendations or discussion among this group if there was more appropriate risk adjusters to raise with them. I don't know, how feasible that would be or timeline, if there's even an option for that. But, if we knew of a solution, then it's probably something at least for discussion.
Yeah, that was the question I was going to pose back to Dr. Berenson, if he had any thoughts regarding that.
Well, yeah, no, there are papers that have been submitted to CMMI with alternatives. They need to be developed, but they're performance risk models that have been advanced as opposed to total cost of care models. The difference between performance risk and insurance risk. Practices need to be paid more for patients that are going to require more of their practice's effort, time and effort, but they don't have to be paid. They shouldn't be paid for the other 97% or 95% of spending that they have no direct control over. So there are such models. CMS doesn't seem to be interested right now in them, and because they need development for application. I don't think. I'm aware that they have been apprised of these alternatives, but if they're still telling you that they're committed to HCC across all programs, I don't think they'll be amenable to an alternative. So the point should be no downside risk.
So Dr. Berkowitz, your thoughts?
I tend to, with respect to the downside risk component particularly, or just in general?
Actually, both.
I think the downside risk adds an additional layer of complexity, especially this soon into the program development. And so I do think it makes it harder. And I think that Dr. Berenson's points are important. I do like, I appreciate the points that were made earlier. I do think that moving to more payers is helpful in terms of aligning. I think that's helpful from the perception of the primary care practices we work with, as well as the patient serving, so as to not have to provide differential types of services. So I think trying to do more of that is useful. I've heard little bits about sort of the way this has been developing related to the Medicaid model, and it does sound like there's a strong difference in terms of the way it's being envisioned for Medicaid versus Medicare. That might be worthy of further discussion at some point. But I think in general, the movement towards more payers and more towards all payer and not just the Medicare focus, it serves our primary care communities and our patients well. And I also, of course, believe that focusing on the medical, behavioral, and social needs and having enough resources to really be able to do that to support primary care success is also really important.
Yeah, very good points. Thank you. Dr. Buzinski, we've seen you come in and out. Your perspective is always valued here. Are you able to communicate?
Yeah, hey, thanks, David. Appreciate that.
Sure.
Sorry, I'm trying to work a little bit here while I do this. But the the downside risk versus upside risk only. I mean, it seems like it's going to be hard to pitch a program to CMMI where there's no downside risk. That seems to be a focus of theirs. I do agree that trying to preserve the fundamental operating funds, such as, if we get funds to do community health workers or social workers or behavioral health, or as we currently do with some care coordination, like those funds should not be at risk. If there's something at risk, I think it should be optional for the practices that feel like they can handle it. But at the same time, for small primary care practices, there's not the margin for that. And so I think that there needs to be some element of it for this to really be palatable to CMMI funding it. But I think for it to be frankly sustainable, it can't be a lot of risk. And really the things that primary care are good at in terms of prevention and, chronic disease management, it's really hard to see those outcomes within a, federal government fiscal cycle. It takes years to see the benefits of optimizing preventative care and so forth. So, we probably, I would think, would have to give at some level on this, but we really can't put the practices at risk. Like downside risk is a threat to the operations of practices. Downside risk is an ideal principle to CMMI, but I'm not quite sure that it really benefits patients in the long run, or that it shows to improve outcomes in the long run. So thanks for listening to my input. I appreciate it.
Yeah, you did bring up an interesting point about the risk curve. I mean, it's always been on a 12-month cycle, but you're sort of presenting a notion that perhaps it ought to be longer.
Yeah, I don't know how we, I'm not the numbers person to do this. And it'd be very hard, I think, to demonstrate those kind of long-term, outcomes. You optimize someone's hypertension and hyperlipidemia management, it's years before they don't have their cardiac event. How do we discuss that. I mean, maybe shorter term goals like we're doing with, are the appropriate patients being treated with those? Okay, that's great. But we're not going to realize the cost savings for years down the road. So I'm not quite sure how they're going to wrap their heads around that. Is it downside risk for not meeting current performance standards rather than patient outcome standards? Maybe downside risk for things we actually can control to a greater extent. I think some practices would embrace that.
Thank you, Dr. Buzinski. We had Will and then followed by Dr. Trumbull.
Great, David. So I agree with the previous commenter. I think we've provided comments in the past to CMMI saying we didn't want a downside risk in the program, and we ended up with track 3, which has downside risk in the program. And I'm just a little worried that we're banging our head against a pretty fundamental philosophy from CMMI, right or wrongly. I think they run the program, they're making the extra payments, and they seem to be pretty wedded to some element of risk. And I think, from a strategic standpoint, it might be better to try and limit the spread of that risk, keep it small, contained to extra payments and not to underlying, PFS revenue, et cetera. I do think that one of the areas where that fundamental disagreement or that philosophy comes from is, I think Dr. Riedman or somebody else said that the original premise of the program was to, invest more in primary care, not try to hold doctors accountable for the 97% of care they don't control. And I don't think that was CMMI's original premise. The original premise, if you look at CPC Plus, there are other primary care-based programs, is that by investing in primary care, you can reduce the hospitalization rate, right? Which is, you invest in primary care, which is 4 to 6% of total cost of care, and you reduce the hospitalization rate, which is 40% of total cost of care, right? So they have a pretty strong philosophy or belief or bet or whatever you want to call it, that investing in primary care can control more or has more influence over the rest of the delivery system than just the 4 to 6% that is actually provided by the primary care doctors themselves. And I get a little worried that if we keep banging our heads against, CMMI's philosophy there, that it will cause them to lose faith in the primary care program itself, right? Which is sort of underpinned by that idea that they get a lot of leverage by investing in primary care.
Interesting. Good point. Thank you for sharing that. So we have
Hey,
Dr.
David.
Trumbull. Oh,
Can I just ask Will to clarify? Will, are you making us, as far as what we have for financial risk here and these bullets, do you have any specific edit that you're suggesting, modification to what we have in these 2 bullets for financial risk?
So, look, whether or not we think downside risk is important or we think it's a good idea, right? They seem to think it's a good idea. And I think we've already made the downside risk point to them. And they basically already said no and gave us track 3 on a mandatory basis. And I'm just concerned that if we keep pushing on, no downside risk, that it's going to cause them to sort of lose the faith that we're fully bought into a model that brings in a lot of dollars for primary care doctors in the state of Maryland. And so, that's like, there's a strategic decision that we need to make, right? Even if we think that downside risk on primary care payments is bad idea, is it worth trying to, take a second shot at convincing them?
So
now,
Will-
I do think this is, sorry, could I just respond to this and then let whoever
Sure.
was jumping in? I do think that this is sort of well phrased and we should draw it out a little bit more, not requiring risk on the core downside primary care payments, I think makes a lot of sense, and I would try to get CMMI to buy into saying, we could have downside risk, but it should be limited only to the extra revenue that's brought into the primary care practice relative to where they would have been prior to entering MD-PCP. right? So in other words, whatever the extra care management payment, heart payment is, like that's the maximum sort of dollars that should be put at risk. And really not all of it should be put at risk, right? So I would try to sequester them to limit the risk, right? But I think that just hitting on the downside risk is gonna frustrate them. And sorry, I spoke over somebody else, so I wanna.
That's fine, Will. I'm happy you said that last piece because I'm on board now, but probably not headed as fast down the road as you are. So just to extend what you were saying, what if the downside risk begins to apply after a certain level of investment in primary care that is required, which may include part of that care management fees, whatever. Because if we say the additional funding coming to the practices, well, we've already made the case that before MDPCP, not enough was invested in primary care. So we're still in alignment with CMS's philosophy that investing in primary care would definitely ultimately improve quality and save cost. But what's that threshold, right, before we apply the downside risk? I think that's where the difference is. And I think that's what people are, in my opinion, probably pushing towards, say, you know, the core primary care payments would not be at risk because we already need that investment to start with to get us to, you know, a place where we can actually see the improvement we're looking for. That said, though, I wanted us to also draw the connected dots back to the global premise of this program, because we keep looking at that chart over and over again, where we're seeing, you know, developed countries, US has the highest spending amongst the 33 OECD countries, but our health indicators keep going down, and that picture has not changed since 1978, 74. So with all these things that we're doing, the point is, if we spend money, we just want to see that it aligns with value. And hopefully all of this changes and innovation that we're coming up with is to go back and look at, you know, that chart again and say, you know what, we see the trend going in the right direction. We don't know how fast, we don't know how much it will cost to get this done. So I think for me, that's just elevating to that global, you know, picture of what we're trying to address, which is we're spending money, right? The cost is still high, regardless of all the effort so far. And what are we still getting for it? Are we healthy? Are we, you know, as a country, and then particularly as a state?
Okay, thank you. Let's go to Dr. Trumbull, followed by Dr. Brzezinski, and then Dr. Behrens.
So thanks. I think a lot of what Dr. Okeke and Will said, I largely agree with. I think that there is an avenue for some limited risk for those things that were added on. But I think one aspect that I don't know that we've really touched on here, and I draw some comparisons, although it's not exactly the same, obviously, but if you think about, so for example, MSSP ACO or other ACOs, generally speaking, if you look at the few companies that are still out there doing it, larger ones typically are going to have economies of scale where they can actually spread the risk across a large number of practices. So what we're talking about here is actually holding each practice accountable for downside risk, as I understand it. But maybe that's another avenue for us. Is this something where we can actually spread that risk across all the practices as a whole? And it might make it more palatable, because I can certainly say that, you know, within our little area of Maryland, we still are trying to keep this ACO idea alive. But it's a struggle. I mean, it's a small number of practices. And so every time CMS comes up and says, hey, we're going to extend track B again, we're all over it because there's no downside risk. And the practices, because of the few that we have in the program, are not really interested in taking downside risk because they feel it, you know, significantly to the risk themselves. So it's just a thought. Certainly larger companies that, like I said, can spread their risk across multiple practices are able to mitigate some of that risk to the individual practices themselves. So just a thought that we might be able to work in there.
Yeah, that's a very interesting point. Thank you. And perhaps Dr. Brzezinski, when you're speaking, you might sort of expand or share with us your thoughts about what Dr. Trumbull just noted.
Yeah, sure. Thanks, David. You know, I really want to echo some of Will's comments that, I don't think we're going to get away from some type of downside risk. And if we just say, no, we don't want to do it, CMMI will say, yes, you are, and this is how you're going to do it. So perhaps we need to just take the initiative and define a way that's palatable to us, to the program as a whole. And, that issue that Dr. Trumbull mentioned of small practices or small ACOs not really able to tolerate the downside risk. I mean, that's real. My practice has lived that. I was fully independent for, many years, and, it was very hard to win at ACOs. It was very hard to see some of these, successes. And then I went through a journey of joining Aledade as a ACO and care transformation organization, had some success there, and then aligned ourselves with Privia Group, which leverages a lot of independent practices and shares the risk across thousands of patients that none of us could really do in our local geographies. And so, there really are varying levels of people who can take these levels of risk. And, large organization with more numbers, you can, and more adept projecting and management, you can handle some of the downside risk, but for smaller shops, it's very hard. And, and here we are dealing with a schizophrenic federal government who says FQHCs are by statute not allowed to take any downside risk. Why is that? Because on principle, they're providing primary care to the most vulnerable people of society. And yet many of us would love to do that, but here they're telling us we need to do it and take risk for that. So it's kind of frustrating principally to deal with a government that's talking in two different ways. But I guess that's the world we live in. So practically speaking, I think Will's point was good. We're going to have to take some downside risk in some way. And why don't we try to define how we'll do it, as opposed to just become, subject to whatever they figure out on our behalf.
Yeah, very good. Thank you. Dr. Berenson and Dr. Lupresti.
Yeah, I was going to suggest just what the last two speakers said, is that, obviously CMS is dug in, CMMI is dug in. So you try to exclude small practices from risk taking and come up with criteria for who should be allowed to take risk. And if it's a large organization and they can game the risk adjuster, good for them. But small practices can't do that. And so I would look to try to minimize the requirement. There will be a requirement to take risk, but try to limit it by whatever criteria. But I think practice size would be one of them.
Okay, thank you, Dr. Lupresti and Debbie.
Yeah, just very briefly, a couple of things. I appreciate Dr. Trumbull's concept of spreading the risk. I think that's very important concept for the small practices that have been discussed. There is economy of scale at many large university settings or other large groups. So I think that spreading the risk concept would be great. We're trying to take care of an entire population of patients, one patient at a time. And it seems, I will venture to say, slightly unfair to be graded on those small groups of patients. Second is something is keeping, I think it was mentioned, almost half of the practices in the state out of MDPCP. Could it be the risk? Could it be the inevitable, what seems to be the inevitable march to track 3? I think maybe it is. And lastly, I appreciate Debbie's concept or mention of the creativity associated with looking at multiple payers. So I think there is something to be said for keeping the creativity in the process by looking at multiple different avenues. That's all I have. Thank you.
And then Debbie, followed by Will.
Yeah, I just wanted to remind everybody of the conversation about small practices versus large and those that can handle.
Debbie, you just froze. Are you still? We can come back to you.
And practices, the way the program is set up, each individual practice ends up being a small practice. I don't know if you heard me. I'm getting a message that I'm
Yeah, we're not
unstable here, so.
You're a little unstable. Let us come back to you after Will. See if that helps. Will.
Thanks, David. So I think some of the previous comments are good, and the idea of pooling the risk, I think is a really good one. I think that also might help us. We can try and sort of strategically message this to CMS to the extent that we want to keep the CTOs and make a strong argument for what benefit the CTOs have. We can package things together, right? We need to keep CTOs because not only do they provide an important staffing function for small practices and an aggregation of, staffing, but also, they help aggregating the risk. And if you want us to take downside risk for our small practices, we got to have CTOs, et cetera. So, there's, I think, maybe a way to be strategic in messaging the sharing of risk as well.
Yeah, and I think Chad, is you're churning about how to change this bullet point. Maybe it is, it is to what Will just noted. It's pooling downside risks as opposed to just saying not requiring downside risk. But you can think about that. And then Debbie, you want to try again, and then we'll try Dr. Trumbull.
Sure, can you hear me now?
Yes.
If not, I'll put it in the chat. My point was just that all practices end up to be rather small, given the way the program is set up. So if there are economies that a system can have because there are 50 some sites, the program doesn't allow the aggregation of those practices. So when we talk about, large systems can handle this, not the way the program is set up, because each practice has to stand on its own. So that would need to be reviewed and changed.
Chad, any thoughts to what you've been hearing?
Really helpful thoughts. I guess I'm curious to hear more from Debbie. I don't know if Debbie's suggesting, like I heard from somebody else, that like Will, that maybe the risk is put on the CTO, or I guess, Debbie, I'd be curious to hear your thoughts if there's a different entity, or because, I think as far as small and big, generally you own most of your practices. So isn't all of those funds put together?
But the way the program evaluation is done, each practice is vetted by itself, right? So we've often talked to you about gaining some kind of administrative efficiencies. Even you have to do reporting 40 or 50 times. There's no ability for a system to bring the practices and the patients together if you're talking about doing kind of risk in aggregate and being evaluated as one large system. It doesn't exist in the program. That was my only point.
Okay, so different from the idea that an organization that has lots of practices might have the reserves that a small organization does not.
Yeah, it's a different conversation, because the way MDPCP is set up by definition, every practice becomes small because you can't aggregate.
Okay.
The way they evaluate in an assent.
And Dr. Brzezinski put a comment in the chat. Dr. Brzezinski, did you want to share that with the group? Okay, I know he's working in the middle of participating. So
I'll just add a comment to what Debbie said. I think also there is an opportunity based on what Chad is saying in terms of how you choose to do this administratively behind the scene. So yes, you do have the reporting out to do it per practice, but in the back end, there's some economies of scale that you can still leverage that a single solo practitioner cannot. But not dismissing what you're saying, but just you're still at an advantage in that sense, in a way.
And Dr. Brzezinski's back.
Hey, David, and everyone. So for that sort of sharing the risk across smaller practices, like the big organizations can handle it internally, but perhaps logistically, practically speaking, all those small practices who don't want to take on the downside risk if we're forced to do that, then maybe have some way to internally aggregate those practices so that hopefully as a whole they could win, and then internally distribute any of those wins to the individual practices according to their performance underneath the larger aggregated group. So that way, instead of CMMI penalizing and paying individual practices, we could maybe, large groups or those so inclined could go and negotiate, directly with the program or with CMMI. But then the smaller practices could be aggregated in some way and reporting their data as a whole, as opposed to, the smaller practices where when you have only a few patients, 1 or 2 outliers can really distort your outcomes. So perhaps do that as kind of like a buffer. So that way it's not all the individual practices taking risk, but maybe collectively they take risk. And internally we have a way of distributing the wins and losses that is more palatable across the board. So at any rate, just a brainstorm, maybe Chad or Will would resonate with that idea. But if we are stuck with everybody has to take downside risk, we have to do some way to insulate and buffer the smaller practices against that.
So Dr. Brzezinski, thank you for saying that. One way I'm thinking that could be feasible based on the framework we already have, just throwing that out there, is if those small practices work with one CTO, then that way it's helpful based, looking at your chat, in order to pull, reporting for quality measures and things, because you have that central body that can help those, sort of small practices, and you're already paid for it, but they have to sort of have that set up where those practices are working with this 1 or 2 CTOs to really leverage that based on the framework we currently have.
Yeah, what I've seen with some of these CTOs and the organizations like Aledade and Privy is they help cull the data and target us clinically where we need to invest in the patients who are the outliers. Because as a small practice by yourself, it's very hard to take the time to look through all your data and your patients and figure out where to target yourself. That takes a level of sophistication that a lot of small practices don't have. And to effectively, engage that level of analysis in real time, not waiting till year end to see if you win or lose. I mean, that's how you win at these, it seems, is you need to in real time be adapting to and identifying the areas where there's unmet needs. And that's really in line with the goals of this program, is finding patients who are not optimizing their healthcare and getting resources to them, whether that's a doctor's visit, whether that's a behavioral health visit, or any other of the resources we talk about, addressing social determinants of health. Those are what really move the needle, because there's a lot of patients who you see in there, they don't need to be found, but there's a lot of patients who would benefit if we find them and we help them and we engage them proactively.
Good point. Laura Russell and then Dr. Berkowitz.
Yes, thank you. So when we're talking about aggregating risk and partnering with CTOs, practices do have the option to partner with CTOs, and CTOs are placed at risk for performance-based payment. So I'm not sure how this might be different. And then the other thing that I'd like to note is a lot of those health systems that do serve as CTOs, they have other accountability mechanisms that we need to think about within the state. So we're contractually required to participate in the MPA, which holds us accountable to total cost of care, whether we touched a patient or not. We have other programs that look at hospital accountability for total cost of care. So would just like to remind folks of that as we think about that option.
Good point. Thank you, Laura. Dr. Berkowitz.
Yeah, thank you. And I know that I think there was a second slide you were going to get to here, so it may be on that slide. But the last several speakers have mentioned CTOs in that context, and I don't see that mentioned here. But one of the thoughts along those lines, and what I think you're looking at related to priorities here, is sustainability and sustainability of funding. And one of the things that I think about in that context, especially with some of the services that Ken and others are talking about here, is what is the splits that relate to that with practice and shared accountability, and whether there's able to be more consistency related to that over time. Because I think when people are trying to do budgeting and planning, it's nice to be able to know year over year what that might look like. So I think some mention of CTOs if we think that that's important in the Maryland context, and some mention of the sustainability, and some split with the practices to enable that partnership and the consistency and sustainability over time.
Yeah, that's very good, very helpful. So I'd like to pause for a moment and note that we have about 5 minutes to our scheduled closing, and ask Chad, what is his preference in terms of obtaining information on the other 2 slides and the last one here? Is this something that can be continued at the next advisory council meeting, or is it your preference to get some submission in writing from folks if they have thoughts, and then review them at a later meeting? What is your timeline and preference? And then Dr. Reedman, your thoughts on that?
Yeah, I didn't want to stop this conversation because we got into really great discussion of key elements that we've been thinking through, risk being probably the top one. I think, if we have a few more minutes to talk, that would be great if people want to stay on, but I also would welcome some written feedback over the next week or so. I don't think this is the end of the conversation, but I do want to have a pretty solid list that doesn't, what I think we have a solid list now, but, potential modifications from this group. I'd like to have that in the very near term so I can get it in front of the HSCRC and the physician engagement group.
Chad, can you just show those 2 slides and go through them very quickly to give everybody kind of a heads up of what we're talking about? That might help focus people's direction to give you feedback.
Sure. So this is the bottom half, the top other items that we heard from previously from the advisory council and from the participants. Participation and eligibility. What we heard is having an entry level track for starters. As of today, track 1 is scheduled to go away after 24. Track 2 would go away after 25, and all practices would be in track 3 come 26. That's part of it. The other piece was, as was mentioned earlier, allow for additional application periods. I think people had called that out. We did have that in here. We heard that consistently. As we identify more practices that are interested in the program, and as the program changes, it may attract new practices, particularly practices that may just not be fully aware of the program, or may be serving populations that become more and more important to the Maryland model. The next area is performance measurement. We heard consistently having a core set of clinical quality measures and utilization with a limited weight on total cost of care, and at the same time, easily captured, simple, meaningful performance measure data with the right incentives, including adjustments for health equity. And then policy and state leadership. We've heard that participants and others are interested in continuing to shift the policymaking and operations from CMS and to the state related to things like quality measures, payment methodology, enrollment, operations, and data. I think that's largely in line with what we're hearing from CMMI anyways, and what their intentions are around the AHEAD model. And then lastly, CTOs, and this one probably warrants further discussion as well. I think the question about CTOs and their role long-term in MDPCP has been raised by CMMI. I think what we've heard is that CTO participation is essential to participation, particularly among small and medium-sized practices, and providing the care management and technical assistance services to practices to ensure they can do things, as Dr. Budzinski and others had spoken to. But that we should consider making some modifications in terms of how the oversight of CTOs and ensuring that they're meeting the care transformation goals of the program.
And I think there's next slide.
Yeah, next slide. These are kind of like the also-rans that we heard that there was interest in, but didn't seem to be as high as a priority as the others, but I wanted to make sure people were aware of them. Specialist coordination, having clear incentives and delivery models such as the e-consult, a focus on social needs, and perhaps providing a health IT platform for all in the program to use. Administrative burden, continuing to address that in the program, reducing burden on practices, and then continuing to have flexibility and waivers. We do have telehealth flexibility right now. We do not have anything around beneficiary inducement waivers, and so that has been something that has been raised.
So, Dr. Reedman and Chad, if it meets with your approval, staff could send out a table and a Word document with these slides, if you will, and with some basic instructions where we might look for any written input as it relates to each item, that being specific to concerns that you have and or potential recommendations on solutions that you might have to these elements. I believe, Chad, if you're trying to get into this physician engagement work group, they have the meeting coming up this Thursday, and then there's one in early April to look at the recommendations. So we probably wouldn't be able to have the time to necessarily step through them again at the next advisory council meeting. Is that, Dr. Reedman, does that seem like an acceptable approach? And Chad, would this be helpful?
Yeah, that sounds good to me.
I agree. Yeah.
Okay, and if we get this out before the end of the week, is it realistic to aim for something by the end of next week, Chad, or is that too tight on time for you?
No, I think if we could get feedback by the end of next week, that would be fine.
Okay.
And that can be part of our update to the physician engagement group, which is, we got a lot of feedback. Here's the initial thoughts. We ran out of time, and we will have additional written feedback by the end of the first week of April, and we can provide you written some kind of written document, let's say the following week.
Okay, I think we can do that. And we did skip over we would be skipping over tonight the update on the primary care work group. So I would ask our executive director if that's acceptable to you tonight, if we defer to the next meeting for this update.
Just point of clarification, is the primary care work group the same as the physician engagement HSCRC group, or are they different?
They are not one and the same. They are different. The physician engagement is different than the primary care work group, which was established by statute. I think Ben is still on, so let me see if he has any thoughts here. I think we may have lost him. Okay, with that, Dr. Reedman, closing remarks.
Just very briefly, again, as always, thanks everyone for the input. These are always very interesting conversations, some very good input. I always appreciate and leave these meetings with rejuvenated for what we can do and hopefully achieve with this. So I thank everyone for their time. I thank everyone for their participation. A lot to think about. So I look forward to our next meeting, and hopefully everyone has a great holidays coming up, whatever the holiday is for you.
Absolutely. And Melanie, do you want to share about next steps and also an update on when the next meeting is scheduled for?
Yeah, so we will.
That's what I thought.
We'll post the meeting summary as normal. And we will be sending the table, as David mentioned. A recording gets posted to the website as well. And David, I don't think we have the next meeting scheduled at this time. And then if you're on the line, maybe you have a better idea than I do.
And
I don't think we have a date for the next meeting.
Okay, very good. We'll get something out shortly with hold the date for the next meeting. And with that, I echo Dr. Reedman's perspective that this is a very useful and important conversation tonight. And I think we made significant progress on looking at some of the key issues as it relates to the MDPCP, and we received great feedback from the council members. So thank you all for your time, and we wish everyone a great rest of the week and holiday coming up. Be well, and we'll talk soon.
Thank you all.